Hello everybody. Today we are going to look at the second lecture on craniofacial growth and development. Okay, the learning objectives for this lecture are to describe the prenatal and postnatal growth and development of the maxilla as well as the mandible. Okay, orthodontic treatment is commonly undertaken in the adolescent age group, and growth and development of the jaws and occlusion influences the type, the timing, and the outcome of orthodontic therapy. So, thus, knowledge of craniofacial growth in terms of pattern of growth, timing, and variability is useful in the treatment planning of orthodontic treatment. Growth may also determine the duration of retention post-treatment that may be needed. Okay, let's look at the skull and jaws at birth. And this is best seen when we compare the skull of a newborn with the skull of an adult. The skull of a newborn consists of 45 bony elements that are separated by cartilage or connective tissue, whereas the skull of an adult composes of 22 bones with completion of ossification. 8 of these are cranial bones and 14 are facial bones. The reason for the lesser number of bones in the skull of an adult is because some of the single bones in the adult, for example, the frontal and occipital bones, are actually double bones in the skull of a newborn. So the bones in the skull of a newborn are widely separated, and when they separated and they have what is known as fontanelles, whereas the bones of an adult skull are in close contact. Now, the face of a newborn is round, whereby the length is roughly equal to width. In the skull of an adult, the length of the skull is more than the width of the skull. Now, the ratio of the cranium to the face in a newborn is 8:1 compared to the adult, which is 2.5:1. Now, this is because the facial skeleton of the newborn is relatively underdeveloped as compared to an adult. Now, let's have a look at postnatal growth. Now, the craniofacial complex is divided into Neurocranium and Viscerocranium. The Neurocranium consists of the cranial vault or Desmocranium and the cranial base, also known as the Chondrocranium. The Viscerocranium consists of the Nasomaxillary complex and the mandible. Here is a diagrammatic representation of the skull, and this portion of the skull is what is known as the neurocranium, and this portion is known as the facial skeleton. Okay, the postnatal growth of the cranial vault. Now, the cranial vault encases the brain. It is made up of intramembranous bones, whereby the bones have formed with no cartilaginous precursor. The growth of the cranial vault follows the neural growth curve and is associated with the growth of the brain. Now, 90% of the cranial vault growth is completed by 5 years, and by 15 years of age, 98% is completed. Now, at birth, the cranial vault is roughly 63% of the adult size. The cortex is thin and the sutures are wide open. The junctions of bone has only a fibrous or periosteal covering, and these widely separated junctions are known as fontanelles. There are 6 fontanelles, namely anterior, posterior, posterolateral, and anterolateral. The posterolateral and anterolateral are two each in number. Now, the fontanelles close at various times, with the earliest to close is the posterior fontanelle, which is closed at birth, and the last to close is the posterolateral fontanelle, which closes at 18 months of age. Now, the significance of these fontanelles is two. One is it allows the smooth passage of the fetus through the birth canal, and number two, the presence of these fontanelles and the sutures, wide open sutures, allows postnatal growth of the cranial vault. Now, what happens if the sutures are prematurely closed? When the sutures are prematurely closed, it gives rise to a condition known as craniostenosis, and the growing brain applies pressure, causing the bulging of the eyeball, increased intracranial pressure leading to headaches, poor eyesight, and neurological symptoms. And it also results in the child having an abnormal head shape. Now, postnatal growth of the cranial vault. The vault grows by sutural growth and also by appositional growth. At birth, the suture ends are smooth, but gradually they become fused and interdigitated. Now, as the cranial bone develops, diplo between the outer table and inner table increases. It develops with increasing thickness of the cranial bone. The inner table is influenced by the brain capsule, whereas the outer table is influenced by mechanical influences, for example, the mastoid process and the supraorbital ridge. Now, at birth, there is no frontal sinus, but with gradual pneumatization and functional stresses, the frontal sinus develops. Okay, now let's look at the postnatal growth of the cranial base or the chondrocranium. Now, the cranial base is not a flat structure, but it has different levels and is divided into anterior, middle, and posterior portions. The anterior being the highest and the posterior being the lowest. Now, what are the functions of the cranial base? The cranial base houses the cerebral lobes. It supports the weight of the brain, and it is a passageway for cranial nerves and blood vessels, and it is also the foundation and truss of facial growth, as the nasomaxillary complex is attached to the cranial base. Okay. Now, what are the mechanisms involved in the growth of the cranial base? We have synchondral growth. We have fill-in ossification of the sutures, which plays a minor role, and there's also cortical remodeling. Now, the synchondruses are located at the midline, so therefore it only contributes to the midline elongation of the skull. The lateral expansion is due to sutural growth in response to the expanding brain. Okay, now these synchondruses are by nature hyaline cartilaginous immovable joints, and eventually with growth they become converted into bone. Now, the growth causes anterior and inferior displacement, and with this the nasomaxillary complex is pushed and it moves downwards and forwards. Now, there's vertical growth of the middle and lower face. Now, the synchondruses have different age of fusion. Now, the spino-occipital synchondrosis has a major role in cranial base growth. Now, this is because the spino-occipital synchondrosis remain open until about 13 to 15 years of age. Now, the cranial base length and the cranial base angle has an influence on facial growth. Now, if the cranial base length increases, the maxilla is carried forward together with the cranial base, and this may result in a class 2 skeletal relationship if the growth is excessive. Now, on the other end, the cranial base has got an angle, and if this angle increases, then the mandible is carried forward, which if excessive can result in a class 3 skeletal relationship. Let's have a look at the postnatal growth of the facial skeletal, or the so-called viscerocranium. Now, the facial skeleton consists of nasomaxillary complex and the mandible. Now, the growth rate is different from the cranium. This is known as differential growth. Now, the facial growth approximates the general somatic growth curve. Now, the face has three dimensions: width, depth, and height. Now, the width is completed earlier than the depth, and the last to be completed is the facial height. Now, at birth, the facial height ratio of the cranium to the face is 8:1. Now, the maxilla is joined to the cranial base. Thus, any growth that is occurring at the cranial base will influence the maxilla as well. Now, because of the inclination of the cranial base, as the growth occurs, the lower face moves down and forward and in an expanding V fashion. Now, the mechanisms of growth involved in the nasofacial complex are translation or displacement, which can be divided into primary and secondary. We have sutural growth and surface remodeling. Now, translation or displacement means there's a shift in the spatial position of the maxillary complex. Now, when we talk about primary translation, it means the maxillary bone itself is enlarging, growing and enlarging, and this happens due mainly to the growth of the maxillary tuberosity, which is a major growth site. Now, the anterior displacement is equal to the posterior lengthening of the tuberosity. Now, secondary translation means the shift in the position of the nasomaxillary complex is caused by the growth of adjacent bones, in which case this is the cranial base, and this is a passive shift in response to the growth of the cranial base. Now, we also have growth at the sutures, and the sutures involved are the frontomaxillary, zygomatico-temporal, zygomatico-maxillary, and pterygopalatine sutures. Now, these sutures are oblique and roughly parallel to each other, and they cause the maxilla to move down and forwards. And it also enlarges the overall size of the maxilla. Now, surface remodeling. All the bony surfaces of the maxilla undergo selective deposition and resorption or remodeling. This occurs on both the endosteal and the periostal surfaces, and this results in an increase in size, change in the shape, and change in functional relationships of the maxillary complex. Okay, now surface remodeling. If we look at the orbits, there's resorption on the inner surface of the lateral rim and deposition on the medial wall and outer lateral rim. Now, the nasal cavity widens by resorption of the lateral walls, and also resorption of the nasal floor. Now, the maxillary sinus is rudimentary at birth. It's only at the size of a peanut at birth. Now, the lining surfaces are resorptive except on the medial aspect. Now, it remodels laterally to accommodate nasal expansion. Now, the maxillary tuberosity, there is deposition on posterior surface and resorption on the endosteal surface. This causes a lengthening of the maxillary arch, which gives a lost space for the eruption of the molars. Now the zygomatic bone moves laterally and posteriorly by bone deposition. There's resorption on the anterior and mesial surfaces. Now, the palate follows a expanding V principle. There's resorption of the nasal floor and deposition on the oral side of the palatal wall. This causes the palate to move downwards. Now, the palatal vault depth increases with the development of the alveolus and the eruption of teeth. Now, the maxillary height increases also with the development and remodeling of the alveolar process with the eruption of the maxillary teeth. Now, the maxillary width increases with up to 5 years of age, and this increase occurs mainly at the intermaxillary and interpalatine sutures. Now, how can we apply the functional matrix theory to maxillary growth? Now, the facial bone encloses the orofacial capsule. Now, growth is due to primary expansion of the enclosed oronasal orofacial capsule. And this orofacial capsule consists of the orbital, nasal, and oral matrices. Now, the growth of the sinus and other spaces also contributes to this expansion of the orofacial capsule. Now, let's have a look at the mandibular growth postnatal. Now, at birth, the mandible is made of two halves. After 1 year of age, the two halves combine to become a single mandibular bone. Now, in the infant mandible, the rami are short, the condyles are rudimentary, but there's considerable growth postnatally, and the mandible grows downwards and forwards. The mandible follows the general somatic growth curve, and significant growth of the mandible occurs during the growth spurt during puberty. The mandible is an intramembranous ossification with secondary cartilage present in the condylar cartilage. Now, the mandible can be divided into parts. We have the ramus, we have the body or corpus, we have the alveolar process, we have the condyle, we have the coronoid process, the angular process, and the lingual tuberosity here. Now, the ramus. Now, the anterior posterior growth due to deposition of the posterior border and resorption anteriorly. Now, this remodeling of the ramus occurs in a archeal position pattern. Okay. Because of this archeal pattern, the ramal angle of childhood, which is more horizontal, slightly upright in adolescence, and in late adulthood it becomes acute. Now, as the ramus is remodeled posteriorly, the the anterior part of the ramal bone becomes part of the body of the mandible, and this increases the arch length. Now this is to enable the mandible to accommodate the erupting molars. As this, the growth also provides for area for insertion of the masticatory muscles. Now, with the remodeling of the ramus posteriorly, the mandibular foramen maintains its position by deposition on the anterior rim and resorption on the posterior rim. Now, the body, as the ramus drifts posteriorly, the length of the posterior part of the body increases. As I mentioned earlier, the arch length increases, and this provides room for the erupting permanent molars. Now, the angle of mandible undergoes selective remodeling, and it causes flaring of the angle of the mandible. Now, the coronal process also follows an expanding V principle. Now, remodeling causes an increase in the height of the coronal process with the apices moving apart. Now, the alveolar process, as you can see in the diagram, the alveolar process is the red colored area. Now, as teeth develops, the alveolar process increases in size and height. This also contributes to the increase in height of the mandible. Now, the chin at birth is relatively underdeveloped, and significant growth of it occurs during the pubertal growth spurts, and it becomes more prominent, especially more prominent in males. Now, the condyles at birth are relatively underdeveloped. Now, the condyles are a major site of growth, but they are not a growth center. Now, the condylar growth increases the length and height of the mandible. Now, but Weinman and Sicker say that the condylar cartilage has intrinsic growth potential, meaning it's a growth center. But the current opinion is that it's the growth of the soft tissue or the functional matrix. This is namely the muscles and the connective tissue, which carries the mandible downwards and forwards, and this causes secondary adaptive growth of the condyles. Now, the superior surface of the condyle undergoes bone deposition, and it also moves in a expanding V configuration, and there's deposition on the inner aspect and there's resorption on the outer surface. Now, let's have a look at the concept of growth rotations. Now, growth rotations were derived from these implant studies done by Bjork in 1955. Now, the clinical significance of these growth rotations are they allow a etiological assessment. It also has a diagnostic significance, whereby it helps to elucidate the nature of the anomaly. There's a prognostic evaluation. It helps in choosing treatment modality. It affects the treatment stability, and these growth rotations can be modified to a certain extent by functional or orthopedic appliances. Now, growth rotations in the maxilla does not occur to a significant extent. Small clockwise or backward or anti-clockwise or forward internal rotation happens, but this is compensated by remodeling of the palate, and thus there's little change in the inclination of the palatal plane or tooth eruption. Now, growth rotations of the mandible, there are few classifications. Now, the original classification by Bjork was he classified it into forward rotation and backward rotation. The forward rotation is further classified into type 1, type 2, type 3. Backward rotation has got two types. Now, the forward rotation, type 1, the fulcrum of rotation is in the condyle. In type 2, the fulcrum of rotation is on the incisal cortex. And in type 3, the fulcrum is on the premolar tooth. Now, backward rotation, there are two types. One, type 1 with the fulcrum of rotation is in the condyle, and type 2, the fulcrum of rotation is in the premolars. Now, Schude's concept of growth rotations is he held the belief that the growth rotation arises because of a mismatch between the vertical growth as compared to the horizontal growth of the jaws. There are two types, either a clockwise rotation or an anti-clockwise rotation. Okay. Now, extreme clockwise rotation can give rise to an open bite, whereas extreme anti-clockwise rotation gives rise to a deep overbite. Now, clockwise rotation is this, and this is anti-clockwise rotation. Now, Profit's concept of growth rotations, he classified rotation as internal rotation, external rotation, and total rotation. Now, internal rotation is rotation of the core of the mandible. Now, what is this core? The core is the bone surrounding the inferior alveolar nerve. There are two types. One is matrix rotation, whereby the fulcrum is in the condyle, or intramatrix rotation, whereby the fulcrum or the focus is in the body of the mandible. Now, external rotation is surface remodeling of the mandible. Now, the total rotation is the final result position of the mandible as a result of both the internal and external rotation combined. Okay, so this is the core of the mandible, whereby it carries the inferior dental canal. Okay, and the rest are the surrounding matrix. And so here is a diagrammatic representation. This is a matrix rotation whereby the focus is on the condyle, and this is a intramatrix rotation whereby the focus is within the body of the mandible. Now, what is the clinical significance of these rotations? As I mentioned, excessive anti-clockwise rotation results in what is known as a short face syndrome, whereby the facial height is reduced. The patient tends to whereby the patient tend to have a deep overbite, prominent chin. Now, the excessive clockwise rotation on the other end results in what is known as a long face syndrome, whereby the vertical facial height is increased, there's reduced chin prominence, and an open bite. Now, the path of incisor eruption is affected as well. In a clockwise rotation, the eruption path is more anterior, whereas in anti-clockwise rotation, the incisors takes a more upright path of eruption. Now, relapse of treatment also depends on the growth rotations. In clockwise growth rotations, now, how do we relate the functional matrix and the mandible? Now, most consider the mandible as a group of microskeletal units. These are the coronoid process, and it's associated with the affected by the temporalis muscle. you have the gonial angle, which is affected by the internal pterygoid muscle, and you have the alveolar process, which is affected by the teeth. Now, the basal tubular part follows a logarithmic spiral and protects the mandibular canal. Now, at birth, the basal tubular part is relatively straighter and it gradually assumes a logarithmic spiral. Now, let's have a look at the temporomandibular joint. Now, because of the temporomandibular joint, the mandible is the only movable bone in the skull. And this joint is said to be classified as synovial sliding gyngymo-diarthrodal joint. Now, what this basically means, if we compare with mammals, for example, carnivorous mammals, the temporomandibular joint is only capable of a hinge movement. Hinge movement means basically a opening and closing movement. But in the human temporomandibular joint, the mandible is not only capable of a hinge movement, but it also can do protrusive, retrusive, and lateral extensions, or a combination of all these movements. Now, the temporomandibular joint starts developing at the 10th week intrauterine life. Now, at birth, there is no articular eminence. Okay, there's no articular eminence. Now, why this is so? Because this allows forward movement, horizontal movement of the mandible to enable suckling. Now, once the dentition is established and there is an overbite, an eminence develops to create the path of movement for the mandible. Now, in infants, the condylar cartilage, articular eminence, glenoid fossa, and articular disc or meniscus are highly vascular and cellular. By 5 to 6 years, this becomes less vascular and cellular, and they become more fibrous. Now, the articular disc or meniscus, which is initially flat with development thins in the center and becomes thick anteriorly and posteriorly. After 20 years of age, the cartilage remains in the superior and anterior part of the condyle and the inferior and posterior part of the eminence. Now, remember the cartilage, condylar cartilage is a growth site, not a growth center. Now, let's have a brief look at the growth and development of the soft tissues, as these have an intimate relationship to the growth of the bony skeleton. Now, lip length. Now, the lip length is defined as the length distance from the subnasale, to the stomion superius. Now, in male, it is about 22 to 24 millimeters. Females is about 20 to 22 millimeters. Now, the lip length continues to increase or grow during adolescence, and the growth in the lip length is more than the skeletal growth. Thereby, lip competence tends to improve with age. Now, lip competence is important for the stability for any overjet reduction. Now, lip thickness, this influences the fullness of the lip, and it's a major factor in facial aesthetics. Now, when incisors are retracted, thin lips tend to become retrusive. Now, the lip thickness increases or grows up to 16 years of age. In Caucasian, this is about 12 to 15 millimeters and is thicker in people of African or Caribbean origin. The lip thickness is usually measured at the level of the A point. Now, nasal growth Nasal growth affects the relative prominence of the lips, and nose tends to grow downwards and forwards, and generally the nasal dimensions and growth are greater in males compared to females. Chin. Now the chin also affects the relative prominence of the lips, and the chin is affected by the bony chin or the mental protuberance as well as the thickness of the overlying soft tissues. Now the prominence is largely affected by the growth of the mandible and less by the soft tissue thickness increase. Now in a Caucasian adult, normal soft tissue chin thickness is about 10 to 12 millimeters. Now, a word about facial aging. Now, as we age, a number of features develop. Now, there will be a reduced upper incisor show. Ideally, this should be 2 to 4 millimeters, and this will reduce gradually as we age. Now, this is also there is also a concomitant increased lower incisal show, meaning we show more of the lower teeth and less of the upper teeth. Now this is due to two reasons. One is because of the sagging of the upper lip, and number two because of tooth wear. Now lips become less prominent, and this is because of the thinning and sagging of the soft tissues. The maxillary incisors tend to become upright. The nose becomes more prominent and the nasal tip tends to drop. There is a reduced vermilion height and the lip commissures will drop. Nasolabial folds will deepen. Okay, that is all for our craniofacial growth, and these are the references that students can refer to if they want to know in greater depth. Thank you.